my research in cancer. I have been associated in cancer research for about 35 years, and extensive research on knowing the cancer's metabolism, prevention, and various pathways. So I was a head and chief of the laboratory for 12 years. Now, coming to our today's topic is esophageal cancer. As you saw, the present overview of the therapies of the esophageal cancer is not so encouraging. Even having a lot of innovative technology has come so much presently. The the precision medicine has been taken up, targeted therapies has come, immunotherapies has come. But if you see overall picture of the esophageal cancer therapy, maximum 5 years overall survival in metastatic esophageal cancer is only 5%. And one thing which I would like to emphasize here is that most of the cancer patient of any of whether not esophageal only, but almost all cancer patients, most of the cancer patients, they come at the later stage of their diseases, and therefore you need to really focus on that particular area. And last 3-4 years, I am looking forward for studying the metastatic cancers because we want to find out something better solution. Now, in this case, if you see the esophageal cancer, you see the radiotherapy overall survival will be 12 months. Chemotherapy overall survival will be 6 months to 1 year. Present therapies like targeted therapies are giving the better results. But even then, the difference between the placebo and the treatment protocol is not much differing as per the cost of the treatment is concerned. Therefore, this particular cost is not been affordable by all the people, patients, and this can be only affordable to the some of the people. And therefore, it is very, very essential to look into the mechanism of esophageal cancer. What is happening? Not only if it is general cancer, but today we are talking on esophageal cancer. So how we can reduce the mortality rate and improve the overall survival time and better life to the patient. So if you see the global incidence of and mortality rate of esophageal cancer, if you see approximately 4,50,000 people suffered from this cancer, and almost 4 lakh patients are died. They lost their life due to the cancer worldwide, clearly indicating that there is a need of better therapy or better program to diagnose and treat this patient. Esophageal cancer occur usually in men and women equal parts. Some of the places they have written men have more than women. Low survival rate and rapid progression of this cancer are the main feature of this cancer. Once this progress, it is progressing very high. Therefore, even the patient should make the awareness of this particular disease, that if they find something wrong in their stomach or something, like they have to really go immediately to the doctor, because progression, it takes rapid progression in this case. Second, despite medical advances in recent decade for treatment of cancer, 5 year survival rate for the patient is less than 20%. More than 80% cases of patient of the cases death from the cancer occur in developing as well as less developed countries. The higher incidence of esophageal cancer in the world is observed in China, northeastern Iran, southeast of United States, south of America, and East Asian countries. Esophageal cancer is the 8th most common type of cancer worldwide and constitutes the 6th leading cause of cancer death. Although esophageal squamous cell carcinoma continue to be most prevalent type worldwide, esophageal adenocarcinoma is quickly becoming the most prevalent type in developed countries. Risk factor for development of esophageal cancers includes low socioeconomic status, consumption of tobacco, alcohol, hot beverages, nitrosamines, which are mainly in the Chinese food. You find this nitrosamines, vitamin C, vitamin E, and folate. With respect to the esophageal adenocarcinoma, risk factor include Barrett's esophagus, gastroesophageal reflux diseases, obesity, and tobacco consumption. Present day, there are no established guidelines for esophageal squamous cell cancer screening. Guidelines for esophageal adenocarcinoma are more well established but lack concrete evidence in form of randomized control trials. So definitely there are so many lacunas if you see in the case of treatment of esophageal cancer. If you see the pathology of esophageal cancer, there are two types. Just now I explained that it is a squamous cell carcinoma of esophagus or adenocarcinoma in some cases. The esophagus does not, cancer does not have a good screening testing. It is not having the early diagnostic actually, but there is need of also understanding the early diagnostic marker in this case. But it can be detected at early stage using the endoscopy every 3 or 5 years in people at high risk. Those who are having these habits, they should check. But generally, I don't think people have a tendency to go and check for this particular thing. But this can be taken as a national program for avoiding this disease, such as Barrett's, which has already explained to you just now. As I told you, there are radiotherapy, chemotherapy, which are not worked so many years, and there are major problems of having the high toxicity of these drugs because they kill normal cells. So their alternative has been found out by the various scientists, clinicians, pharmacists, and everyone working in this area. And the targeted therapy has come into existence. People were very much hopeful that this will give better solutions for cancer treatment, and it has given definitely. But still, there may be lot of improvements needed. Now, what is targeted therapy? Targeted therapy is mainly based on some specific target and signaling pathways that cancer is going. And that particular pathway has been obstructed by two types of agents. One is monoclonal antibodies raised against that particular antigen, and some of the small molecules. So here you can see some of these things. Major target in esophageal cancer, which I have specifically mentioned, is EGFR. They give cetuximab and lapatinib as the main drugs they have been given. This is antibody. This is a small molecules. HER2, EGFR. These all therapies are going on. This is the immunotherapy. PD1, PDL1. These two are the immunotherapy has been means checkpoint inhibitors are used in this particular cancer. CMIT. This is also one of the recently approved drug for this esophageal cancer treatment. So if you see the overall picture of the targeted therapy, I have already shown that the overall survival time in this case are not much significantly different, which is giving a really patients more relief to the treatment. And therefore, there is a need of understanding this particular disease more specifically than present situation. Therefore, what we thought that my work, I already explained you that my lab, I have established the two specific laboratories. One is the molecular diagnostic laboratory for cancer diagnosis and stem cell research laboratory. Being a tissue culturist, I thought of understand the various mechanism of cancer development. As you know, the cancer develops at various stages. It's have initiation phase, uh, promotion phase, then give the invagination and metastasis is the last stage. So what today we are going to work on the metastatic cancer. So the goal of cancer eradication has been overshadowed despite of the continuous improvement in the research and generation of novel cancer therapeutic drugs. One of the major exciting problems in drug resistance, due to which the paradigm of killing all cancer cell is ineffective. This is one of the major drawback which has to be looked into the problem, and today we are finding out some of the solutions, the hypothesis which may help in future therapy of the cancer. So major problem is the drug resistance. Who makes the drug resistance? Which are the cells are making the drug resistance? And that is today's topic for our presentation. The tumor microenvironment plays critical role in inducing drug resistance besides cancer development and progression. And this particular area has not been much studied in view of the therapy of the cancer. And here, I think most of the things are involved because see, I am also an electron microscopist. When I have initiated my work in Cancer Research Institute for my doctoral work, I was studying the electron microscopy of oral cancer, where we can see that how the basement membrane of the oral cancer gets break and then the cells are invaded. That I have already shown and published in very long time, 1995, 96 or something. So this is a very important area to be studied, which today we are looking forward for this. Recently, many efforts have been devoted to understand the role of tumor microenvironment in cancer drug resistance, as it provides shelter, nutrition, and paracrine niche for cancer cells. This is one of the most important factors to make a cell drug resistant cells to be resistant to the drug, and then all efforts of the clinicians really go in vain. The cancer-associated fibroblast, one major component of the tumor microenvironment, reside in the symbiotic relationship with the cancer cell, supporting them to survive from cancer drugs. And this year we are now today. So how these cells are promoting the cancer cells is very well seen in our experimental studies also. This also, when I was doing my experiment, I really got this particular fibroblasts shown they are highly proliferative, and this is the one of the reason that this tumor grows very fast, so that I have been observed. So what is cancer associated fibroblasts? Whether they are different from the fibroblasts? Yes, certainly. So cancer associated fibroblasts are activated fibroblasts in the cancer stroma present in many metastatic tumor. These are mainly involved in the metastatic process. That you should remember. In early stages, we know the cancer can be cured. If we find it early stage, there are the possibility of various present conventional therapies also can be. But once the cells goes to the metastasis, these are the notorious cells which needs to look into this. So cancer associated are the most prominent cell type within the tumor stroma and important players in cancer microenvironment. In general, cancer-associated fibroblasts have been known to have distinct morphological characteristics as a large and pulsed cell distinguished from the normal fibroblasts, which are thin, wavy, and small spindles that we will see now the pictures, some of the pictures from my laboratory. Cancer-associated fibroblasts drive tumor progression by directly stimulating tumor cell proliferation through the secretion of various growth factors and cytokines. Here also we have confirmed these findings by isolating these fibroblasts from the metastatic esophageal cancer. That things I am coming further. Activated cancer-associated fibroblasts contribute to cancer progression by inducing angiogenesis and contribute to invasive growth of cancer by secreting several proteases such as matrix metalloproteinase, cathepsin, and inducing the epithelial to mesenchymal transition. These are the major process which happens when there is an invasive process. I have just now told you how the basement membrane get broken, and that is broken because of these particular enzymes which degrade. That time we were not knowing that which enzyme, how to allocate these enzymes, but now we can very well study this by various gene expressions, proteins, and everything that I have already studied in my study. The identity of cancer-associated fibroblasts is also poorly understood, and cancer-associated markers with absolute specificity has not been identified much. There are. When I have seen I have surveyed the overall literature for cancer. Most of the studies are from the Asian countries, from China, Korea, and Japan. So there is a need of really thorough study has been done all over the world in this area. Now here you can see the one of the picture which shows the cancer-associated fibroblasts we have shown in red. This is a dangerous. This can come from the disease-free fibroblasts. This can come from mesenchymal stem cells or endothelial cells. So, and these have their further stromal cell recruitment, secretion of tumor promoting growth factors, cytokines, ECM remodeling, angiogenesis EMT, that is epithelial mesenchymal transition. Now, what is the relation between esophageal cancer and cancer associated? Esophageal squamous cell carcinoma is one of the most aggressive malignant tumors with 5-year survival rate of only 10%. Cancer-associated fibroblasts has been seldom been discussed in esophageal cancer despite its significance in cancer progression. Only few studies have investigated the biological role of tumor stromal stroma, including angiogenesis in epithelial squamous cell carcinoma. Now, in 2014, Sang Yoon Ham from Korea has shown histological classification of cancer-associated fibroblast correlated with the prognosis of esophageal cancer. He has clearly shown that the cancer, he has shown two different types of cancer CAF. One is mature and immature, and clearly shown that presence of this particular associated program, there is a poor prognosis of esophageal cancer. So we can just overview this. Esophageal carcinoma CF is correlated with the prognosis in esophageal cancer. They showed that 52 cases were classified as mature CF phenotype and 64 as immature phenotype. He has just classified as per his histological appearance. In immature cancer-associated fibroblasts were significantly associated increase in microvesicle density and enhanced infiltration of tumor-associated macrophage. I will show the picture in the next slide compared to the mature stromal phenotypes. So here what happens, they degrade all the extracellular matrix and of the tumor microenvironment. So they see this little bit, density is reduced. So there is an increase in the micro density of this cell. So both increase in micro NVD and infiltration of TM they were correlated with the poor prognosis of esophageal cancer. They further suggested that the histological characterization was also associated with the EMT phenotype of ASCS shown by immunohistochemical expression of mesenchymal markers and E-cadherin expression in this tumor biopsy. Now, where E-cadherin comes, it is a adhesive molecules. So this help in down-regulation of E-cadherin. There is a more motility of these cells to go to the invasive metastasis. The complete EMT phenotype characterized by loss of E-cadherin expression was significantly more frequent in immature cancer-associated phenotype than in the other phenotype. The immature cancer-associated phenotype was strongly correlated with increased overall survival and disease-free survival and was strong independent prognostic factor for overall survival and disease survival. So this is one of the very important area to be looked into the. Now this is a normal picture. Here you see there is MVD. You see this. These are regions, and these are the normal fibroblasts which are very long and distinct. Whereas here you see there are the fibroblasts which I will show you the actually culture picture of these cells in my study. So this is, you see the normal fibroblasts, and this is activated. This get activated to cancer-associated fibroblasts. This is a malignant. This is a normal functioning. While cancer-associated fibroblasts, they can come from any of these cells in the epithelial mesenchymal transition, and they are the major part in progressing the tumor. Now, what are the properties of cancer-associated fibroblasts? See, what cancer-associated fibroblast is? It gives tumor cell proliferation. This all has been confirmed in my studies. ECM remodeling, angiogenesis, immunosuppression, chemoresistance, promotion of the tissue invasive metastasis, and maintenance of stemness, that is a pluripotency. So these all factors need to look into the when you are really working for the therapy, and whether these factors can be targeted or something like this in this esophageal cancer may give the better result. That is the things we are done. Now, this work I have done in, as I already told you, in Jaslok Hospital Research Center, and studying important characteristic of cancer associated. What I thought, I have been working with a lot of material in my lab, and I thought that why not to culture the plasma of esophageal metastatic esophageal cancer. And when I did that, I got this type of cells which are the highly proliferative, and when they are identified, they are a cancer associated fibroblasts in liquid biopsies. So we can even don't need to go for the tumor biopsy for understanding its mechanism in esophageal. You can do with the liquid biopsy, which is one of the major advantage of this particular uh, um, this particular cell, because they cross EMT and they come to the bloodstream as a cancer associated fibroblast. They can typical fibroblast by having a little bit different shape, which I am showing you. To study to show the morphology of cancer associated fibroblasts under the phase contrast marker. These are my steps of the studies, which are how I have gone for this. Then study the show the morphology of cancer associated under the light microscope with various staining methods. Isolation of RNA from well grown cells of molecular marker studies. I have established a cell line actually. It is in the passage 30, and this cells we use for this study. Study the pluripotency marker, which will give the stem cell stemness of these differentiating markers, metastatic markers, adhesive molecules, and chemokines markers, which I did by the PCR, RT-PCR studies. Then I did the scratch assay for the metastatic potency of the cancer-associated fibroblasts. Treatment of the cancer-associated fibroblasts with chiton nanoparticles to show the inhibition of metastatic potency if these cells are exist. So because what is our aim here is to understand not only the cells, but whether those cells can be have some inhibitory factors by some of the our nanomedicine or something like this. That was my whole concept, and that paper has already been published by my one of the student, Dr. Ashutosh Shetty, who is presently in Chicago University. Now coming to the my observation of this thing, you can see these are the cancer-associated fibroblasts. These are the H&E staining. This is Alzheimer's staining, showing the some of the granules in these cells. They are little bit, swollen than the normal fibroblasts, and this is the showing that there is no adipocytes in this culture. Now, cell growth rate, I have another growth here, but that I am not talking. Presently, the cells growth of these cells are growing very fast and has a doubling time of 25 hours. In 25 hours, it gets double. So, this is very highly proliferative cells, which we saw with the growth factor. Then we have done some studies with some morphological studies, how the cells grows. When we plate about 50,000 cells, in 24 hours, they become very confluent, and in 48 hours, you see lot of metastatic, metastasis cells in these cultures, and they are actually piling up each other. So, so they have encourage independent properties. So they are almost malignant type. And then future experiment, I am coming for the next slide. Here I have done the gene expression studies on cancer-associated fibroblasts. I have studied the OCT4, SOX2, 9 These are the pluripotency genes which are present in the stem cell. They show that these are the stem cell property, have a pluripotency, means they are having the property of continuous growth properties. And you can see in control, you get OCT4, SOX2, 9 all three expressed in these cells. So expression of OCT4, 9 SOX2 and 9 in cancer associated shows that they are the stem, they have the stemness property. Coming to the metastatic gene in the cancer associated fibroblasts, this is the picture you can see in the control cells. You see VEGF positive. VEGF is an angiogenesis marker. It indicates these particular cells have the angiogenic factor. E-cadherin is totally absent, indicating these are the cancer-associated fibroblasts which is undergo EMT transition. Then MMP1 is also expressed in this, indicating there are metastatic cells. MMP9 is highly expressed in this metastatic cells, which is already reported in several cases. So, scratch assay, if you see upper picture, scratch assay for showing metastatic potency of cancerous relate. When we do the scratch assay, I am not explaining how to do the scratch assay. When we do the scratch assay, in 24 hours, see how much migration these cells does. You know, they cover very fast. In 48 hours, they are confluent. There is no space you see in this, indicating they are having high mobility and high proliferation, and that is the one of the reasons these tumors grow very fast. Therefore, the treatment for this cancer is you have to fasten the treatment and properly take care of the patient before it goes to the uh, cannot be controlled. So what I did is I have used the uh, chitosin nanoparticles to show that this particular cell phenotype can be changed. And this is a, the chitosin is a naturally polymer obtained by deacylation cheating. It is biologically safe, non-toxic, biocompatible, biodegradable polysaccharide. Everyone knows, I think this is not a new thing. Chitosan nanoparticles have gained more attention as a drug delivery carriers because of their better stability, low toxicities, simple and mild preparation method, and providing versatile route of administration. Their submicron size is also suitable for mucosal route of administration, as the oral, nasal, or ocular mucosa, which is non-invasive route, and this is very important. Chitosan is one of the most functional natural biopolymer widely used in pharmaceutical field due to the biocompatibility biodistribution. So I have done some experiment with the similar cell. So I am repeating some of the slides with the picture showing that how the cells looks after treatment. Now here you see they are confluenting in 48 hours, having a lot of metastatics. They have encouraged independent growth. They have, contact inhibition. You can see in this cancer, they are highly malignant. But when we treat this with the 24 hours, see the structure of the cells. If you see still high MAG, you can see very clear structure, monolar cells. If you see in the culture, they both have plated 50,000 and given a treatment in 24 hours. There is a lot of changes in 48 hours. You see they are like a spindle shape, like a normal fibroblast looks like. So this shows that only chitosan nanoparticles by treatment of natural you can reverse these phenotypes. So this may be a probable solution for the treatment in future. Now, if you see the cell growth curve, this is one of the important factors. What is our aim? To control the growth. And this can be controlled by giving 100 microgram of chitosan nanoparticle. And you see the growth rate has come down tremendously. It is significant that 25 hours to 30 hours, this growth rate, only for after the 24-48 hours treatment. If you see the gene expression, you can see the OCT4 and SOX2 are down regulated completely. NINOC never affect because I have done extensive study in NINOC, but NINOC is a more stable genes in Potency genes, but you always get a variation in OCT4 and SOX2. And here you see the stemness of these cells are coming down. Their proliferative activity are clearly show that they are down regulated. Now, if you see the metastatic gene, in treated, even the angiogenesis factor is still appear because there may be more concentration of drug may be required. So here you have to really more focus. Picadin negative in all these things. MMP1 is also little bit down regulated, whereas here also you get down regulation in VGF, but not much. But MMP9, which is one of the important gene or protein in metastatic cancer, this has been down regulated, and there may be chances of controlling this metastatic in future studies. Here you see the scratch assay, which I have already talked about the upper, that there is a high proliferation in 48 hours. You can cover this thing Whereas in this case, chitin nanoparticle treated cells, you see there are still big gap and the cells have almost lost their motility. And so the treatment, different treatment, now I have given 100 microgram. If you increase the treatment, or you have to do the dose response for this, which needs to be done in the confirming these findings. So in conclusion and future direction, I have to say, overall it shows that cancer-associated fibroblasts are the building block of microenvironment and play a crucial role in modulating cancer drug sensitivity. Therefore, understanding the exact role of cancer-associated fibroblasts in esophageal cancer could minimize the existing challenges of drug resistance in this disease. This intervening these pathways of cancer-associated fibroblasts in microenvironment of tumor by use of innovative cancer drug discovery may suggest the better therapeutic management for esophageal cancer in near future. I think this gives overall message that you need to have cancer-associated fibroblast study. Also, if the patient is more metastatic and not giving response to the treatment, present treatment. So, if this particular things has been further used in the clinic, that will be, I think, better advantage about reducing the mortality of this cancer. Thank you. These are my researcher. Ashutosh is not here because he joined afterward. But these are the some people who have actually collaborated, means helped me this work, establishing this work. And thank you very much for giving me this opportunity to talk. And I hope it is more clear to you people and students. And this work is very, very essential in near future for looking for the better therapy of cancer. Thank you very much.
Thank you, Dr. Pravin.
Okay, thank you.
Thank you, sir. Sir,
So I can
as
come
your
on the screen
presentation,
now. Pardon?
yes, sir, you can.
1 minute.
So, as always, your presentation brought a new insight from current research.